How we doing? Welcome to the inaugural Friday Forum for the fall 2018 semester. We're glad to have y'all here. For those who aren't regular attendees for these, most every Friday during the semester at 1 o'clock, we meet in this room to have conversations and to hear presentations from people who are doing interesting work. So I encourage you to keep an eye out on announcements on social media, on our website, etc., to hear what's going on. Next week, our Friday Forum will actually take place Tuesday evening at 7:30. Okay, so no Friday Forum next Friday. Instead, it will be in here. Actually, I think we're going to be in the recital hall, 7:30 p.m. On Tuesday, September 11th. The program will be, it's a musician who has put the Odyssey to music. It should be a fascinating program. Today, though, we have a conversation that I think is important and timely, to be sure. And I think you agree by your presence here reflecting that. We are talking about food and public health in Mississippi, and we have three experts on the topic. Immediately to my left here, we have Dr. Victor Sutton, who is the director of the Office of Preventive Health at the Mississippi State Department of Health. And he's going to provide a bit of a general overview of the state of public health in Mississippi. And then next to him is Qula Madkin, who is a registered dietitian and consultant, who is an expert on a number of things, and she's going to share that with us today. And then at the end of the table, we have a face that might seem familiar to a few of you here. She's an alumna of the college, Dr. Compretta. She is at the University of Mississippi Medical Center, where she's an assistant professor of preventive health and pediatrics, and also is at the Center for Bioethics, and about 8 other lines of her email signature that I didn't remember fully for today's purposes. But she's an impressive and accomplished alum who is no doubt representing her alma mater well. So what's going to happen, each of our panelists is going to speak for a few minutes about what he or she does and what he or she feels like is most important regarding the topic at hand. We'll then have a back and forth conversation with them for a few minutes, and then at the end we'll have some audience Q&A. And if I didn't say so at the beginning, my name is Kenneth Townsend. I wear a few different hats here at the college, and I'm really glad to see y'all here with us today. We're looking forward to the conversation ahead. I will very, very gently moderate it, but my goal is mostly to get out of their way. So without any further ado, I'm going to hand it on over to Dr. Sutton, who I think is going to do a short PowerPoint for us. Dr. Sutton, welcome.
Thank you for having me. I'm glad to be here. I'm Victor Sutton. I'm director for the Office of Preventive Health with the Mississippi State Department of Health, and also the PI for the Community Engagement Center for the Jackson Heart Study. So what do we do, or what do my office in preventive health? So I like to start off by saying, look at the slide. Let's say that's anywhere in Mississippi. Let's imagine that there's 3 Millsaps students on the side fishing. And all of a sudden, you see a baby floating down the river. So you're sitting there, you say, so you have 2 students who jump out, and they go grab the baby. In the next few seconds, you got one more baby, another baby coming down, and they're floating down. So you jump out there, you grab them, and pull them out the river. Then they look back at the other student who's sitting on the bank saying, what are you doing? You see me over here pulling these babies out. And the student says, settle down, and then he or she starts walking upriver. And so, why are they walking upriver? Because she's saying that, hey, I got to find out what's causing these babies to flow down this river. And so that's how I like to describe what we do in our office, is that we're going to always need physicians, emergency care to pull those babies out and provide immediate assistance. But at some point in time, we're going to have to go upriver or go upstream and get to the root causes of what's going on, what's the problem, and get to some of those kind of issues, because that's where we're going to really get our win. So our office, promoting healthy lifestyles, preventing, controlling disease and injury, protecting health through policy, systems, and environmental change. So what does that mean? We're talking about prevention efforts, we're talking about systems, we're looking at faith-based communities, we're looking at churches, we're looking at work sites, we're looking at communities, we're looking at healthcare, we're looking at everything. How can we work with some of those systems? And I think it's important for us to kind of operationalize what is public health. And this is from Charles Edward Winslow. Public health is a science and art of preventing disease, prolonging life, and promoting health through organized efforts and informed choices. So generally, when we talk about public health, we're looking at the whole society, and what you hear more is about around population health. I'll be negligent if I don't operationalize a couple terms that you hear all the time, and that's health disparity and health equity. And these are two terms that you're going to hear a lot when we talk about public health in general. Essentially, health disparity, as you can see, a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. We talk about health equity. We're talking about attainment of the highest level of health for all people. If I live in Tupelo, and if you're not familiar with Mississippi, or if I live on the coast, I should expect the same care regardless of where I live, what race, color, or creed, or how much money I have in the bank. I should have an expectation to have the same kind of health anywhere that I go. So we're talking about health equity. Just to give you a little snapshot of Mississippi, and we talk about the burden of chronic disease. These are the leading causes of death. You can see that as it relates to heart, as it relates to cancer. This is some of the issues that are killing Mississippians. We always have rankings. So usually Mississippi, unfortunately, have on a number list of the worst first list. So we want to have the highest rate in cardiovascular disease. We're second around diabetes, second around cancer, and second around obesity. I'm going to talk a little bit more about obesity. Complex issue, but I wanted just to kind of show this slide as it relates to looking at children. Unhealthy children can become unhealthy adults, and then it's an economic factor. We know just in general, for a short example, when folks are working or when we have instructors here, if they're not feeling well, they're not going to be here. So health directly relates to that and relates to a number of different factors. But it's estimated between 147 to 210 billion kind of cost economically. And when we talk about issues of obesity, it's a growing issue. And so I'm just going to give you what's in the research and what's literature. You can give you some evidence, and that's why I say evidence. You can debate the other stuff, but even in this country, you have a woman that's almost being charged with neglect because in Britain they were talking about whether or not this is neglect or abuse, and threaten to take this kid away. Just a simple indication of kind of where we are as a society on some of these kind of issues, and something that's a little bit more controversial is issues around obesity being one of the last areas of acceptable discrimination. Is there issues? We always have issues with whether or not you want to charge for two seats as it relates to airplane ride, as it relates to what someone may think about somebody just based on a number of different factors, unfounded. So I think it's something that is growing in the literature as it relates to some of those issues. But I also want to mention about just a framework for addressing obesity. It's a complex issue, again. And so what you see is a slide that in the first level is individual factors. There's genetics involved. I mean, that's proven. There's genetics involved. We're all not made the same way, not built the same way. We don't have the same kind of frame. Social factors, and there's personal factors and what have you. So that's on the individual level. But there's also an understanding that your genes doesn't necessarily dictate your gene size. So again, those are some factors. There's behavior settings. Home, school, community, and work site. It's documented, we spend most of our waking hours at someone's work site. We spend 8 to 10 hours a day at someone's home. So is that environment conducive for healthy eating? Do you have healthy options? Do you have healthy snacks? You may have a Millsaps. I don't know how progressive and awesome Millsaps is, but not all work sites reflect that kind of environment, that kind of culture. There's sectors of influence. You see a growing interest as it relates to promotion around healthier options by businesses, by fast food restaurants, because they kind of get it. There's growing, but for a long time you couldn't. When you walk down the aisle, there's a reason in the science to why sugary snacks, candy bars, and sodas are glassing that you see and prominent around grocery stores and those I just want to kind of frame some of that for you, but I also want to talk a little bit about nutrition and physical activity as we kind of lead into what's the main topic for this discussion as it relates to food. We have, here's some of the adult stats and some of the children's stats. I think the take home for this slide is recent evidence would lend itself to say that if current trends continue, our kids are going to have shorter lifespans than their parents. And I think that's troubling. I think that's something that we all need to kind of really wake up and be cognizant of that our kids may have a shorter lifespan than their parents. Farmers markets. As we talk about food and what we do from a public health perspective and what we do out of our office is around farmers markets. Working with farmers markets that exist but no one knows about. There's probably, for where each of you guys may live, there's probably a farmers market that you know about or maybe that you don't know about. And so we try to work with those that are available to help promote them, to help open up opportunities for recipients of WIC, to open up opportunities for the community so they know that they're here. There's a number of different issues that I don't have time to get into while some are successful and some are not. But they're a great opportunity. And we work with a number of different partners to kind of help promote farmers markets and even going into the whole knowledge of mobile farmers markets to go around the community. Because there is an advantage for that farmer in real estate to have access and to get their produce out to local folks, farm to school, and a number of those different issues. So trying to create those kind of environments. If there's one thing I want you to take away is I want you to take a really good look at this slide. And so when we talk about public health, we're talking about the community and we're talking about everybody. But health and public health does not exist in a little vacuum here. It's all connected. If you look at the slide and you see a community that has poor quality schools, you have occupational hazards, there's high levels of unemployment, where there's discrimination, where there's racism, where there's a whole lot of poverty, it's gonna lend itself to having a higher incidence of violence, infant mortality, malnutrition, substance abuse, obesity, stress, heart disease, and all these other kind of issues. But if you look over in communities that have access to health care, quality public education, access to healthy foods, access to transportation, health insurance, good incomes, you're still going to have some of this other stuff. You're just going to have way less of it. You're going to have way less of issues around malnutrition, HIV and AIDS, and issues around violence. So there's some connectivity. It's all interrelated. And some of those issues I just mentioned are what we call the social determinants of health. So I want to just really just kind of give you that whole background as we really sit back and enjoy the other experts on the panel about public health and just kind of think of it as just a connected system. Thank you for your time.
Good. Well, this is funny. I normally don't wear heels. Today I chose to wear heels, so I can't walk around out. You'll hear me stomping everywhere. Can everybody hear me? I'm going to be very quick and brief. I love to talk, and it's normally pretty fast. So if somebody in the back does this, that means I'm slow down, so I will. So I'm really excited to be here. My name is Qula Madkin. I am a registered dietitian. I'm a health coach, certified diabetes educator, and some other things. But what I want to do today is really take this conversation to you more on a personal level. I want to share a little bit about what I do as a dietitian, but I also want to share what I'm hearing from clients that I have, families that I have, whether it's working with individuals or at work sites or if it's working on a grant. I've gathered a lot of what folks are telling me that's affecting them as far as it relates to food and why they make the choices that they make, and I want to share that with y'all. So just a little bit more about me. I'm born and raised in Mississippi. I was just telling the panelists, I've moved a lot in 2 states, Mississippi and Alabama. So I've traveled the world. But born and raised in a small town, Purvis. Anybody from Purvis? No. Lumber? Yeah, all right. Every time I say it, I have at least one person who has gone through Purvis or is from the area. So I'm from Purvis, Mississippi. I graduated Purvis High School, and that was in '97. And we had a population of about 2,700 folks. One red light, Ward's Restaurant, which is still there, and I worked there as in high school. And that restaurant is still there. I'm a mom, and my oldest daughter there in the green, the tallest girl, is actually way taller than me now. She's only 13. So I'm a mom of 3 and a wife. So I want to start with some definitions because I think this is very important. When I say nutrition, I immediately get weight loss. Folks want to know, how do I lose weight? And I said, wait a minute, I said nutrition. I didn't say anything about weight loss. Nutrition is the process of nourishing or being nourished. And I want people to really, and I really work hard to help folks understand that a dietitian is not just here to help you lose weight, although we do that too, but it's about encouraging nourishment. And when you are focused on being healthy, nourishment is extremely important. I want to make sure you also know the definition of a registered dietitian, because this can be very confusing for folks. There's a difference between a nutritionist and a registered dietitian, okay? And I'm not saying, yes, I think as a registered dietitian, I've been credentialed, I've gone to college, I've done a lot of different things, but we are considered the nutrition expert. There are food and nutrition experts credentialed by the Commission on Dietetic Registration who can translate science of nutrition into practical solutions for healthy living. So we don't just do weight loss, number one, and number two, we are credentialed. So I want to talk now really quickly, and I know this is a quick discussion while I'm here on the podium, and we'll get into it as a group on the panelists. But some of the barriers that you guys, folks that I'm working with, are telling me that they face and what that means. So, first thing folks tell me is too expensive to eat healthy. Do y'all believe that? I got a lot of yeses and nos. And I'm going to tell you something, this depends on the person and their situation. Because sometimes for some folks, cost is an issue. College students, it's an issue. I eat peanut butter and jelly a lot. I'm telling you, I would scrape up some quarters, go to Wendy's, get the junior bacon cheeseburger. At that time, it was 99 cents. It was 106, so I could find 6 pennies and $1, and I had a meal. So, and it also depends on the situation. There's families out here who don't make a lot. So, sometimes food can be more expensive to them. So we have to remember that. The environment where people grow up or where they live. I know Dr. Compretta is going to talk a little bit about food deserts and some of those things. People are living in places, some of us have lived in places where there's not a grocery store where you could actually go get fresh food. Or there's the gas station, and that's what's there, and that's what's available. Or it is very expensive for you to catch a ride out of your neighborhood to go to Walmart or to Kroger. So the environment is also very important. And what people know and where they live really determines how they eat and what they eat. Time. A lot of working parents, a lot of single moms. As Dr. Sutton mentions, we are spending a lot of time at work, working 10 and 12 hours a day. It's difficult to go home and cook food, so time is an issue for folks as well. And then there's so much nutrition confusion. Is it this diet? Is it that diet? It's, what works and what doesn't work. And we haven't done a good job clarifying that information for folks. So there's a lot of confusion out there as well. And then choice. When I'm talking to other healthcare professionals, they don't want to hear this, but people have a choice. They can decide, I don't want to eat healthy. It was very striking to me. I worked as I told you I can talk, but I'm going to be quick. I worked as a consultant for a drug and alcohol rehab facility in Huntsville, Alabama. I loved that job. I learned so much. I met so many people. But what I learned that just struck me to my core was that there were people who liked doing drugs. And their goal to leave rehab was to go back and do drugs. And they would look you dead in your face and say, I like doing drugs. So we do have people who like to eat what they like to eat. And that sometimes we can't change. But we can set the stage to help them when they're ready. And then we have good old Southern diet. Is that a barrier? What do y'all think? Yeah, okay. talk a little bit about that, and I'll be wrapping up. When you guys think of Southern diet, what comes to mind? Fried chicken. I can't hear y'all.
Sweet tea.
Sweet tea.
Cornbread.
Cornbread and biscuits and gravy and all these things, right? Things that we all enjoy at times, or sometimes all the time. When I Googled Southern diet, and I'll give it a try, these are the images that come up. There's a lot of negative things that come up. The American College of Cardiologists actually published an article in 2017 that the worst diet is the Southern diet. Do y'all believe that? Y'all are saying yes. And I think this is where we have a significant opportunity to think differently. And as a dietitian, I really work hard to make sure I'm encouraging, especially Southerners, because I'm born and raised, I'm a Southern girl, that everything about our diet does not have to be bad. We have to shift our thinking, not just me as a dietitian, you guys as teachers and educators and moms, about the Southern diet, because everything in the United States about the Southern diet says it's bad, bad, bad. But what I will tell you is, it is not that bad. It's what we do to the food, right? What I remember fondly as a child in Purvis, Mississippi, is walking with my friends for hours picking blackberries, eating plums right off the tree. My mom having my sister and I go outside and crop greens that she would cook in the evening for us. So there are really significant opportunities that we control. So everything about our diet and what we eat as Southerners isn't bad. And we all have to really take responsibility for that and do a better job with what we're putting out in the atmosphere about what we eat here in the South. And we got to do that, of course, by changing that. But I think the first step is to be more positive, because we have a lot of wonderful, as Dr. Sutton talked about, the farmers markets, a lot of agriculture. The farmers market in my neighborhood in Purvis, Mississippi, was my neighbor who was 101 and she's still living, and she had a huge, just a yard full of greens that people could just walk by and grab. My parents still to this day have a small garden that they, when I say they have 2 freezers full of peas and corn and okra, they do. And they could feed the community. So these concepts that we're hearing about community gardens, they're not new. We're just not doing them like we used to. And I'm going to end with this. Change does not roll on the wheels of inevitability, but comes through continuous struggle. That sounds really large, but that is how we have to think about nutrition and food also. Because we all know, we try to diet, we try this, and it's not something that happens overnight. So I'll just end with that and enjoy discussing with the panelists. Thank you guys so much.
Great. Thank you, everybody. My name is Compretta. And I'm from UMC, just down the road, so it's really great to be here with you guys. Thank you for being here. I'm going to talk a little bit about the culinary medicine program that we have at UMC that we started a few years ago. And it's growing by leaps and bounds, which I think is really good because thanks to Ms. Madkin talking about the kind of individual and behavior issues, we're going to look at the practitioner side, right, of that. And what are we doing with those practitioners? How are they conveying nutrition and dietary information to their patients? So when I got asked to do the panel, one of the questions was, can you give us an idea of what the largest or the challenges are to food and public health? And when I started to think about it, I thought, well, one of those challenges, especially over at UMC, is getting the need for practitioners to convey the information that we have. We have a wealth of wonderful dietary and nutritional information, but how do those practitioners convey it in everyday, accessible ways? Right? And I love this. Can you read it? I love this because I feel like this cartoon really sums up what happens in the exam room so often. When you have a question about nutrition or health related to food, you get this really long, complex answer that doesn't necessarily answer what you need in a way that you can understand. So it says, and that's how you determine the number of net carbs per serving with this lovely equation. So that I think is the challenge. And I always believe that within challenges we have opportunities, right? And so that challenge at UMC specifically, in our context and writ large, I think everywhere, presented an opportunity for us at UMC to kind of address that. And so a little background about our program. We realized that our students and our practitioners who are in the clinic had a really limited nutrition education. It wasn't in the curriculum very well, and when it was just these snapshots. There wasn't a coherent kind of message, and really no way for them to learn how to practically relate that to patients. So we started a discussion about 3 years ago about this. What do we do? And because we also realized that we were asking practitioners in their clinics to address diet-related chronic disease at increasing rates. So we were not preparing them, but then we were putting them in the clinic and saying, okay, now you address this. Okay, and so we were doing a really poor job about giving them the tools that they needed to treat those conditions that Dr. Sutton showed us, that litany of problems like diabetes and hypertension, obesity. All of those are diet-related chronic diseases. So we started looking, and we looked just to the south of us, to Tulane. They created the Gold Ring Culinary Medicine, the Gold Ring Center for Culinary Medicine. And they created a curriculum that's only licensed by medical schools, that you can license it. And so we began talks with them, and we licensed their curriculum. And it's really good. They allow you to use it, but you can tweak it for what you need. And so we piloted it with students in a cooking club. I wrote a grant, and we got pop-up kitchens, and we took over the student union, and we cooked and cleaned and messed up the kitchen in the student union. And we had overwhelmingly positive responses from students. And as you know here at Millsaps, if you can get your students on board, the administration will follow, usually. And so we were really excited. Our classes were over completely booked. We had waiting lists, and so we were really excited. And since then, we began to incorporate it into a longitudinal nutrition curriculum in the medical school. So what is culinary medicine? Okay, it's not necessarily nutrition or dietetics, not solely preventive medicine or internal medicine, and it's not solely culinary arts or food sciences, but it combines all of this. There's a good definition by Puma that says it is an evidence-based medical field that blends the art of food and cooking with the science of medicine and nutrition. And so it's really where we come at culinary medicine and creating this kind of robust program that uses evidence-based research, but then also talking about practical issues with food and how we relate that to patients. So we started our culinary medicine classes. It's about 3 hours long, so it's a commitment for students. They initially have a didactic session with a registered dietitian. So one of the things we also want to show practitioners is that they have resources with registered dietitians that aren't utilized nearly as much as they should be. And so we have a registered dietitian who teaches that class, not only to convey that information, but also to show future physicians, you need a registered dietitian in your clinic. If you're going to address these issues, you need to recognize the resource and expertise of others. They're usually taught a culinary technique, something really cool with chopping or mixing or cooking, and then they cook. We give them recipes, and they, on our pop-up kitchens, cook those recipes, and they're usually really different. So, for example, we'll take, you'll see a video in a second, but we'll take a traditional recipe like just spaghetti and meat sauce, right? And we'll have them, one group make spaghetti and meat sauce, one will cut that meat in half with portobello mushrooms, so you're cutting down substantial fat from using a vegetable, half of a vegetable instead of all meat. And then we'll have one who just does lentils and sauce. And so how does that taste? And then we all get together and we eat. So we all sit around a big table, we talk about the meal, and then they have to clean up, which is really fun, because I really like to make them go do the dishes. So they all get their hands dirty as well. So it's a lot of fun. Basically, we have 4 goals for this program. And we want to relay basic nutrition and dietary information to our students based on evidence-based research so that they know that sound information and research that's out there. Just like Ms. Madkin said, there is so much noise about nutrition, so much noise. And we need to make sure that our practitioners are not adding to that noise, that they have very clear and evidence-based prescriptions or treatments that they're talking to. Okay, we want to make sure that they understand that. And then we really want to make sure they understand the socioeconomic conditions that affect food choice. You can't go tell someone that they should eat healthy and buy a lot of organic fruit when they can't purchase it or they don't have access to it because their community isn't a food desert. So we really want them to understand issues of access and cost and education. The idea that there's a great example in a community I've worked with that they had a community garden. They were sending the vegetables home, but the moms were really busy and had trouble, and some of them didn't necessarily know what to do with them. So they started an education program and started a crock pot club because they needed to know, well, what is this and what do I do with it? So we need to recognize that there's issues of education as well. And then we want them to learn those essential tools to communicate practically in everyday ways the evidence-based nutrition concepts that they understand, to relay those to their patients effectively. So we spend a lot of time about that, having them speak back. What do you mean? How would you say this to a patient? What would you, how would you convey this in the clinic? And then they practice those culinary techniques. That's how we get them there. They get to do hands-on cooking, and so that's part of the grab. That's the hook. Great. So I'm going to show you just a little bit so you see real life what happens. This video is a little dated. My hair is short, which but it gives you a kind of an idea of what we did. Maybe.
Our second event. There are going to be medical students from M1s all the way to M3s, and we have 20 students tonight, and they'll all be cooking 4 different dishes. So the very beginning is they learn a cooking tip, so chopping or some really new novel cooking techniques, and then they will have some instruction about dietary information. We're going to be going over the Mediterranean diet tonight. It's all evidence-based, so they get a lot of good information that they can pass on to future patients, and lots of good clinical information. And then we move into the fun part, which is the cooking. And so they're broken up, and everyone will be on a team, and they, from boiling pasta to chopping peppers to making sauce, and then we all put it together and we eat together and we have a discussion about the difference in the dishes, the calorie content, the nutrient density, and then we get to eat. Enjoy.
I love to cook, and I've always thought that it would be a really great idea to teach med students and people in nursing and any allied health like how to cook, so that when they talk to their patients, they can sort of advocate for it and have some real world tips maybe that they can give, as opposed to just like, okay, well you should cut some salt, some salt out of your diet this way. Give them more practical advice, like, well I do this, and it makes a lot more sense, I think.
I think it's important to be able to connect with patients like that way, because through food, and to be able to tell them like a healthy way to do something.
It's nice to know what you're speaking about.
Right. Absolutely.
Do you wish you had this when you were in school?
Yes, yes. And I found in our very first event that students had questions that they'd been waiting to ask and had not had an opportunity to ask them. And so they came out really interested, really hungry for this information.
I'm really interested in finding out how she substitutes like salt for different herbs and spices, so I definitely want to incorporate that.
I really like to cook, and I think it's a really interesting and important thing to learn for our patients, especially in Mississippi, where the Mediterranean diet can be really beneficial to so many people.
This program is based off the Tulane Culinary Medicine Institute, and we got together, talked about it, really wanted to bring it here, and then the curriculum piece was a little slow going, and so we decided to start it as a cooking club. But hopefully this will morph into something much more substantial, long-term in structure.
What I try to work with patients on is we can make whatever your means are, the reality of your situation. If it's that you have to go to McDonald's to feed your family of 4, and that's the reality, we want to work on how can we make the best choices then at that point. It's really about moderation and learning to make the best choice within your means. If you can't buy all fresh vegetables, but you can get the can, that's better than not eating a vegetable. Just rinse the can, rinse that water out to get some of the salt off.
So do you cook at home?
I attempt to cook at home.
I'm not that good at it. I'm still learning.
We have spaghetti with lentils. So it's the first time I've ever tried this recipe or tasted it. We're adding lentils to the spaghetti, and then we're gonna make some awesome sauce to go along with it. And hopefully we'll like the final product.
My husband was really excited, so he's really pulling for some great new stuff.
Does he expect to be the first one to benefit from your knowledge?
Definitely, yeah. He thinks I should practice a lot at home.
We're family tonight. We eat together, we cook together, we clean together. So thank you for being here. I hope you had a great time. Look forward to seeing you.
I learned a lot. Learned how to substitute some different things for meat, how to cut down calories and increase fiber all at the same time, and without sacrificing a lot of taste. I learned kind of some salt substitutes, and I don't know, just a different way of looking at it.
Will you come back?
Oh yeah, I'll definitely be back.
Great. Sorry for the redundancy, y'all. In my excitement for the program, I said most of what was in the video. So, just to give you an idea of future directions from here, we're in the process of building, or not building, but process of looking to build a teaching kitchen. We have space identified and we're looking for funding. We're hoping to expand our classes beyond the School of Medicine into the other schools. So there are 6 schools at the School of UMC, School of Nursing, School of Dentistry, health-related professions, the John D. Bauer School of Population Health. I'm forgetting one. I'll remember in a minute. And then we would like a 3-tiered prong where we would have education programs, then we'd have community referrals. So we would work with clinics to have patients who are newly diagnosed with diabetes or hypertension to come into our class for 6 weeks sessions. And then we'd like to do practitioner sessions with practitioners who are already out in the clinic, have them come back and do CEU credits, and so they can additionally get this information. All right, thank you.
Great. Wonderful. Is this working? Yeah. Thanks so much to you all. So now we're going to move into a short discussion component with our panel before we open up the floor to y'all. One of the things that became apparent when y'all were talking is this is a big issue, a big challenge, big opportunity, depending on how we want to look at it, both. It involves lots of different people who have lots of different expertise. I'm wondering, given where you sit, if you look around and say, man, if only it was easier to facilitate conversations with this group of people or with this population, it would be a lot easier to advance our work. Do you find it to be the case that in your respective fields, which overlap in certain respects, but are also different in other ways, do you find easy opportunities to collaborate with people who have similar kinds of objectives but are approaching it from different angle? Or do you find yourselves often working with your own colleagues in your own specific discipline and not so much collaborating with others? Does that make sense? Who wants to take that on first?
Am I taking it first? Yeah, I think collaboration is obviously very important. But I do find there are great opportunities to collaborate, but I do find, especially when you're looking at grants and things of that nature, there's sometimes some silos. I just, be frank, folks feel it's my grant, and they may not want to share or bring in other people just for certain reasons. But there's a lot of great collaboration going on. I do think there's much of an opportunity for more, though.
I would just second that. I find that this conversation about food and public health is happening a lot. And you will find out about a program and you're like, wait, what? We're doing that too. And so I do think there are missed opportunities because I think folks end up getting siloed. And they're, following the networks they know. And so if we could have a larger conversation, which is why I'm really glad about this, and getting to know what else is out there. I think that's just part of the problem. But I do think this conversation is happening a lot in lots of different places. We've been able to collaborate some with other groups, but we have to obviously with registered dietitians and Tulane and things like that. But I do wish there was more ability, a more kind of a food network, not at the Mississippi Food Network, Dr. Beatty.
And I would just want to say that, the work that we do we can't really do it without partnerships. We know there's a lot of issues around silos and some of the issues around communication, but there's really a lot of great things going on in the city and around the state. We're just kind of scratching the surface. Just kind of speak particularly to one of your points, it's a complex issue. It's a very complex issue. We have some partners here that I know that are working on various things, such as financing for grocery stores and trying to attract grocery stores, and because it's still a business model. There's not even grocery stores in places where they can't make money. And so there's a lot of different sides to it. There's an economic side and a business side to it. So partnerships are just a way of doing business that you have to do. But it's a complex issue, but it's on a lot of different fronts. It's community embracing some things, it's changing some mindsets, it's changing some cultures. So yes, partnerships is essential, and there's some great things. There's some great things going on in the city. I hate David Watkins and Jeff Hood wasn't able to kind of talk about some of the things that they're doing, innovative type things that they're doing in the city to address issues around access and affordability.
Great. I've got one more question, and I'll let y'all discuss amongst yourselves briefly before we open it up to the audience. And I recognize that this is a question you may not feel excited to answer too directly, so I will all forgive you if you try to skirt around it. How well do you think elected officials and our leaders in our state take seriously the problems of public health and are properly supporting solutions to help improve public health in Mississippi, including, but not necessarily limited to, the food component? And I didn't tell you I was going to ask that question. I didn't know I was until I sat here. So there you go.
You look the best.
I think you started. You wanted it, so you
I don't think we have a vision for that. As a state, in terms of governmental vision about health as it relates to food. I think where we are with that is individual blaming. I think people are making decisions and it's their fault. Because if we look at food deserts, so these panels I just brought for your viewing pleasure, but in another hat, we did a statewide food education program that cycled through public libraries where we would have these panels up. And as you can see, one of them is food deserts, and it's about access. And I know there have been lots of efforts to do fresh food financing or tackle issues of food deserts. And I know one person who worked on a bill, I think it was 3 years ago, fresh food financing bill. They couldn't use the word food desert in any of the flyers they gave to state officials at the legislature. Because if they looked at it, it was too political and they considered it too liberal. So they had to use creative wording. And so there was all this backlash. But I mean, we have to name food deserts. It's about accessibility. We can't ask them to eat healthy if they don't have the food in their communities, or they're traveling long distances to get there and have to pay someone to drive them or pay the cost of their own vehicle. And so I think that there is a real lack of understanding about that and inability to name what it is so that we can tackle it. Because I think they would rather rest in the victim blaming where it's their fault or they should just figure it out and they should just eat healthy. And so that's where I stand. I didn't shy away from that, did I?
And I agree with a lot of what Dr. Compretta said. I think the opportunity is obviously there. We've talked about that a lot. There is a lot of victim shaming. There are a lot of lack of resources. But I think what's most important is the folks who are making those kind of decisions that you asked about, Kenneth, they have either come out of a situation that some of these folks are in, or some folks are in, that it's up here now. It's not here where I'm speaking of where I came from Purvis, Mississippi. I still have to remember that and pull from that when I'm educating folks and trying to put programs together and develop material, because I have to know who the audience is and what's going on in those communities and what's going on from a public health standpoint. And I think sometimes they're so far away from it that it does not matter to them because it's not their neighbor, it's not them, it's not their family. And so I do think we have an opportunity to educate, and we should be bringing the people who need the services to the table. Because a lot of times, there are seats at the table, and it's filled, but not with the right folks. So I think we can definitely do a better job of that.
You guys know I work for the state, right?
Let's not try to provide it out.
I see some colleagues here, and I approach this question with just kind of giving some evidence and some facts, so I can't run from facts. So I see Ms. Newkirk and Jaleisha here for the help. So Ms. Newkirk, how much money do we get in the Office of Preventive Health for these kind of efforts? State money?
None.
Correct. So we talk about a number of different issues as it relates that I just kind of presented. And the appropriation that we get from our elected officials as it relates to the state is zero. So what I do and what we have been successful in doing is that we do write a number of grants, we do partner a lot, and bring dollars into the state to try to address some of these kind of issues. So, you know, it's a real question, not to say that our elected officials are not aware of some of these issues, but I think we have a lot of opportunity to really prioritize and get further down the road to address some of them. One would be nice if there was a larger investment if these issues are important.
Great, thank you. All right, so I do want to open up to the audience shortly, but now that you are all on this stage together, we talked earlier about the value of collaboration and discussing across disciplines. Is there anything that you all would like to ask each other before we hand it over to the audience? Any questions come up during any of your colleagues' presentations? I want to follow up on that you think would be most productively done now.
I've already asked. We've already said something.
Great. Well, let's go ahead and open it up to the audience, and now it's your turn. Yeah, right here towards the
Right, Lumberton.
Lumberton, yeah.
I work for an anti-hunger organization, nonprofit. I have kind of two questions. I'm not sure the first is really a question, but it would also help me if their names were on the table because I've already forgotten.
Oh, sure. So Dr. Victor Sutton, Ms. Qula Madkin, and Dr. Caroline Compretta. Sorry, we'll try to do that next time.
Dr. Sutton, I was in Nashville this year, and I noticed that one of the Dollar Generals had some fresh produce. So I was surprised and pleased to see that. I guess that's not really a question, but Dollar Generals, I think their goal is every 15 miles or something like that. It's insane. But anyway, Dollar Generals is something I'm interested to see if they'll kind of pick that ball up and run with that as far as food deserts are concerned. My question is for Dr. Compretta. Do you have an opinion on prescription food boxes?
That's a great question. You want to take that one? Mary Margaret Saunders is, she works with Dr. Joseph McCoy, I'm so sorry. But they are working on that. I think that's an interesting, there's a lot of debate around that. And at UMC, there's a lot of debate about not going down that path because of medicine, right? They recognize that if there's a condition and they need actual medicine for it, that they want to go down that treatment path. You asked for my opinion though, which is always, I will qualify it. I think we need to try both, to be perfectly honest.
Tell the audience what is meant by prescription food box.
Sure, that means that a doctor would write a prescription for a food box. You would get, they would basically say if you had a diet-related chronic disease, they could say that you have a prescription for, X, Y, and Z, but in terms of vegetables or lean meats, those kind of things, and you could turn those into a place that had agreed to fill those prescriptions, just like you would a normal prescription for a pill medicine. You would bring that in. And so it's recognizing that food is medicine. And so I did at one point in my slide have the famous quote from Hippocrates, which is, let food be thy medicine and medicine be thy food. Took it out though. thank goodness, because it was too long. So I think we need to try both. To be honest, we recognize that the pill form of medicine is not the only way to go, and we're not going to tackle some of these. They are diet-related chronic disease. While diet may not cover all of it, we are tackling that at all, that part. And we need to address the nutrition part. So I think we need to do a better job of doing both.
Right here.
Oh, where do I start? I'll just introduce myself first. I'm Siobhan Chapman. I'm an organizing
anybody in this room. I got some leaders here. Raise your hand, leader, Lord, man. Raise your hand, leader Scott. Some of our issues include living wage employment, organized debt for the schools, food access is a huge deal. We have a lot of stuff coming around elections, so forth and so on. But again, Millsaps just became a member through Reverend Lori Levels. Anyone knows her? And we're looking for more energy and more involvement from the folks who are here attached to Millsaps. So with that said, so we talked, I want to just speak briefly about some of the work that we have been doing. The establishing cash care in South Jackson was a part of our work because our interest in that was ensuring that fresh food access stayed within Kroger. But our current priority is to take fresh food access to scale. So we, in fact, are working, one of our other member institutions is Hope Enterprise. And so the Fresh Food Finance Initiative that took place in New Orleans, that's in Burnaby, Baton Rouge, we are working with, in consult with those folks in our member institutions, in our team, our fresh food access team, to see what in fact will work for Jackson. Because I think it was you, Doctor, who said, you know, there is a business aspect to this, and what actually may work in one place as far as that grocery model may not necessarily be the same type of thing that we want to do here. And so we have a lot of people who have expertise and personal experience. So just a word about how we arrive at identifying issues that we're going to organize around. We have what are called house meetings, where there are conversations among people within our institutions. They come and they answer questions. What pressures are facing you and your family, and what are you prepared to do about it? And so we have everyone who is directly impacted at the table, and then folks who may not be directly impacted but have a lot to offer. So David Watkins Jr., Jeff Good, Cindy Ayers, and so forth. And you know, so this team is really emerging, and there's a lot of energy. And in fact, we have asked the city to allocate $250,000 to their Fresh Food Finance Initiative. And we are working with Mayor Lumumba, and we are holding elected officials at this level accountable to, you know, the priorities and the needs of the community. I could talk all day just like you, but I won't. But I just wanted to let you know that I vibe with every piece of what was said today, and I'm inviting as much input, and I want to collaborate, okay? And if you are all, I think you said people are working in silos, but if you do know of energy and collaboration that's already occurring, you know, to some degree, I want to talk to y'all after and get some more context, and also get to know you guys. And anyone else in this room who may be interested. So I know that was long-winded. But the question perhaps is, you know, are you aware of any real collaborative efforts? Like, I'm aware of some stuff going on, but what are the collaborative efforts that you are aware of that are not siloed, that may be useful in the process that I'm speaking about, that we're now moving forward on?
Well, I think the work that y'all are doing is great. I think that having those people at the table, and I think sometimes we just gotta bust down doors. And, you know, we can definitely speak afterward, just some of the things that I know that are going on that may be helpful. But I think, you know, we just have to keep pushing. We can't just decide, well, they're not gonna do anything, or nobody's gonna give us funding, so we just don't stop. We have to keep pushing the doors down and making the path, because it's very important work. So, great job.
Thank you. Yeah, I mean, all of our organizations are dues paying members, including Millsaps. And we put our money where our mouth is. We're not showing up to anybody's doorstep saying, hey, this is what you need to do for us. And frankly, I mean, we have some solid leadership here in Jackson, but we still have to hold power accountable, and we need to be positioned to do so. And we need to make sure that concrete steps are being taken, hence $250,000, so over 3 years, $750,000, leverage the county, leverage about billions of dollars, you know, in hope. But, and with that, we also have to have infrastructure that's built, and we want people at the table to help shape that, who really know what that is, who aren't going to know what that's like, because their senator, such and such, they're gonna come and go, but who will still be here? Millsaps College, you know, Hope Enterprise, Tupac Community Services, so forth and so on. So, you know, we really want to make sure that we're not leaving it up to somebody else what our destination is.
Okay. Thank you. Yeah, great.
And I confess I don't know what the latest is on the lottery, but is there any chance that the funds that, if we do have a lottery, that are generated, I know they're debating what to do with it, could perhaps go to fund some of these initiatives, since that seems like a really critical thing that would help a lot of the other things going on in the state? No. And if not, why not, since the money hasn't been allocated, why, I mean, is it too late to start saying this should go towards public health?
All I will say is, have we seen the money for where the casino's on? To be perfectly honest, that was supposed to go to education. And last time I looked, you know, we need money in our schools. So, while I think there's an opportunity there, I think that conversation should start. Don't know, you know, past experience may not be a good indication.
Great question. And I would just say this, is that the reality is that there's a long list of individuals that have their hand out waiting for the lottery money. And public health is really, really far down on that list. Not only are we far down on that list, but we just went through some very drastic cuts in our state where the health officer, Dr. Curry, had to make some decisions as to what are we going to do and what we're not going to do as an agency. And so that's really the current state of public health. And the majority of our budget is non-state funds. It's funds that we generate through licensure and certification, through a number of restaurants and that pay for fees and different those kind of things that go back into our budget. Indirect costs for every grant that I bring in, I provide infrastructure to the public health system because there's a certain amount of dollars that goes back into to the agency. So I think it's a good question. I think hopefully that there's some literature out there as it relates to legislatures and their readiness for change. And at some point, it has to be a point where they're ready to change. All of a sudden, there was no lottery, and then the winds kind of blew, and all of a sudden, everybody was on board. So, and it happens like that. And if you ever had time to really go and see how legislation is made, it'll really turn your stomach sometimes, and depending on who's in the room and what's the last things being discussed and how that got on to that particular piece of legislation. So I'm hopeful and optimistic that the budget will change and that incrementally we can get back to where we need to be, just for basic overall public health. We always say that if public health is doing their job, nothing happens. So if you're not getting an outbreak of TB or there's not some airborne virus or you're drinking water and not getting sick, public health is working. If you go and eat restaurants and you're not coming down or things are not happening to you, then public health has done its job. So if everything is going right, then nothing happens. And we won't even talk about emergency preparedness and some of the role that we play in some of those issues. So I'm optimistic.
All right, Kristen at the back, and that I think will be our last question. Yeah.
Thanks. So I teach in the philosophy department here, and in the last few years started teaching an environmental ethics class. And just this summer, I read a little article about the federal farm bill. The massive amount of money besides about it's the agricultural bill, basically, for the nation. So our state senators, Doug Cochran, they're part of that conversation. It's not a Mississippi bill. Is that something that you all talk about? My understanding is there's an enormous bias, for corporate farms, which seems to me to be counter to the kinds of farming that is being talked about in this room, local community, that sort of thing. Is that part of something that's part of conversation for you all?
We're going to fight over it. I'm not an expert on the Farm Bill. However, we are having conversations, and I'll speak just from my UMC home, about the fact that it is funding corporate agriculture, which ultimately, predominantly focuses on the production of corn. which then is produced into high fructose corn syrup, which is then put into baked goods or to shelf-stable goods, processed goods that are often cheap. And then, and kind of the cycle of that, and how, I'll kind of circle back to that idea of when we were talking about victim blaming, that we end up telling people that they're eating the wrong foods, but we're not providing them access because we're funding the exact same thing, or the exact thing that is affecting their food choice and their health later on. And so I don't think there's enough conversation about that, because I think if it is a massive, it's a mammoth bill, and it's not written very easily and accessibly to understand it. So I think that that's part of the conversation, is that it is written so obscurely that it's hard to decipher. And I think part of what we need to do is begin to make that more accessible, because I think the more that's known about that, well, hopefully the conversation will shift. I think that we do have a lot of that kind of local farm movement is really going on. Jeff Good and David Watkins are working on that and making sure that they're connecting local farmers to opportunities, economic opportunities, because it has to fit into the business model. It has to be economically viable for people to be able to do it. And so I think there are good examples of alternative ways to farm. Those, however, have not reached the large scale by which the Farm Bill addresses and is funding agriculture. So I don't think that I have a good answer to that. I do recognize what's going on, but I do think we're funding the conditions that we are then having problems with later. We're funding the kind of the obesity and diabetes and these chronic health conditions. But yes, so I think we need to have more conversation about what is in that Farm Bill, because there's also lots of stuff that's not related to food. There's all kinds of stuff that gets stuck in there. So.
I was talking about health. I'm an ag business guy in this state, and the Farm Bill is a big political football ball. And if you look at a lot of agricultural people, the big ones that they always say we gotta feed the world. So if you think about that, when they say they gotta feed the world, it means that they have so many people on this world and they don't have, so they gotta get it out the world. That's why they see GMOs, genetic modified organisms. You see a lot of push for mass production, because the hidden word is they gotta feed the world. So right now the focus is on, hey, we're just trying to feed the world, compared to targeting, your own people, so to speak. So, and then secondly, it's also a constituent giveaway. That's not necessarily really political. So, for example, the Farm Bill, they target farmers. They actually pay farmers to not grow sometimes, and a lot of people don't know that about the Farm Bill. And if they can't, so it was actually a study back in the day where it was they paid the farmers to build it, and they turned around and used the bottle, dig the ground, and burn food in the ground, because it was affecting the supply and demand, because you didn't want to give away food. So it's a political football, and that's something that could be addressed, but it's so misconstrued and it's used to do it. For example, welfare is tied into the Farm Bill, and the reason why that's tied into the Farm Bill for several reasons. And I don't want to get into all that, but it's just a big political football.
All right, so this gentleman right here wants to add something. Thank you very much for that help. And then I do want to be respectful of people's time, so we probably will start to wrap up.
Just one additional thing, a shameless plug. If you go follow the Partnership for Healthy Mississippi on Facebook, that's who I work for. I shared an article today about 3 reasons why you should support the Senate Farm Bill, not the House Farm Bill. And one of the things we're keeping an eye on is the work requirements for SNAP benefits, which is a really big deal. And so that's just, I want to put 2 cents with that. That's a big issue we need to be watching in Mississippi, is work requirements. And our friends at the Mississippi Center for Justice are really going to be keeping an eye on that. So that's
Great.
what that is.
Great, thanks so much. This has turned into a rich conversation. I don't want to cut it short, so I hope you do feel free to mingle for a bit afterwards. If our panelists have a couple minutes to stick around, maybe you could snag them, but I know they have already taken a good bit of time out of their busy schedule. So I'm really grateful that y'all were able to be with us today. You sparked some interesting and meaningful conversation, and look forward to. I hope I can have your same optimism that things are slowly, steadily getting better. So let's give it up for our audience.